Yeah, welcome. Today's lecture is the continuation of the last lecture, that is Chemotherapy of Tuberculosis, Part 2. That is second line drugs in the management of tuberculosis. So in the last class, we have seen regarding the introduction of tuberculosis, the transmission of tuberculosis, the burden of tuberculosis globally, and the statistics which are available, the Indian statistics. And apart from that, we have classified anti-tubercular drugs into first line, second line, injectables, and newer drugs. And in the last class, we have seen into in detail regarding the first line drugs in the treatment of tuberculosis. Now, before going to the second line drugs, there are a few questions to be answered. Like, I had a question from the audience in the last class that if two drugs are given in combination, in which one is a static and the other is a cidal drug, and if the organism is highly sensitive to cidal drug, what happens? Really, it's a good question. Suppose if the two drugs are given, one is a bacteriostatic drug, the other is bactericidal drug. And if the organism is highly sensitive to bactericidal drug, what is the net result? Yes, definitely. When the bacteriostatic drug and bactericidal drugs are given together, the bacteriostatic drug will cause inhibition of the multiplication of the microorganisms. Hence, the efficacy of the bactericidal drug reduces. What will happen? The efficacy of the bactericidal drug will get reduced or decreased. There's one classical example for this. If we combine oxytetracycline with penicillin, penicillin, when it is combined with oxytetracycline, that is a penicillin being bactericidal, tetracycline is a static drug. When both of them are combined, it will have an antagonism, especially when treating pneumococcal meningitis. Okay, so penicillin and oxytetracycline antagonizes when they are used in the treatment of pneumococcal meningitis, but this is not always true. There's another example. If you take, when we combine penicillin along with sulfonamides, rather than antagonizing, they have a additive effect. That is the reason why whenever a bactericidal drug is combined with a bacteriostatic drug, the net outcome may be either there's a drug antagonism which is seen with penicillin and oxytetracycline, or there might be an additive effect which is seen with penicillin and sulfonamides. Is it clear? I think this will be clear for you now. Then apart from that, in my last lecture, the first part, I have been categorized streptomycin into the first line drugs. But whereas streptomycin in some textbooks, it is given as second line drug. So here, if you look at, when you talk about the various regimes, regime modalities or category 1 and category 2 treatment modalities of Mycobacterium tuberculosis, we have first, that is intensive phase, and second, which is called as continuation phase, or initiation phase and intensive phase. Wherein in the intensive phase, we either add 4 drugs or we add 5 drugs depending upon the nature or the seriousness of tuberculosis. First phase. So here in the first phase or initiation phase or intensive phase, the drugs which are used are isoniazid, rifampicin, ethambutol, pyrazinamide, and the 5th drug will be streptomycin. Or else if there is any allergic reactions, or when there is an ADR profile with ethambutol like optic neuritis, we can interchange ethambutol to streptomycin. That is why in some textbooks they mention it as second line drug, and in some standard textbook like CAPREOMYCIN, it is mentioned as first line drug. So it does not make much of a difference. So leaving that aside, to look into the tuberculosis and the various types of tuberculosis. Primary tuberculosis, we have secondary tuberculosis, we have reactivation type of tuberculosis, the tuberculosis which is called as miliary tuberculosis. So generally, most of the people, I said in the last class, around 40% of the population are having infection with tuberculosis, and that these tubercle bacilli may be in a quiescent stage for years together in the lung, as a caseous lesion in the lung, or it might be a circumscribed lesion in the lung, which can be there, or these bacilli can be present in the lung for years together, unless and otherwise our immunity, the patient's immunity gets depleted. Once the immunity gets depleted or reduced, these bacilli will get reactivated. They get reactivated and result in formation of a reactivation type of tuberculosis or secondary tuberculosis. And these organisms will track back through the bronchial vessels and may spread to the different parts of the body, which is called as miliary tuberculosis, and so on and so forth. That is regarding the basic introduction of tuberculosis. And apart from that, if you look at, we have seen the basic primary drugs used in the treatment of tuberculosis. There are 5, like RIESP or rifampicin, isoniazid, ethambutol, pyrazinamide, and streptomycin. So we have dealt these drugs in detail, which are used as primary line drugs for the treatment of tuberculosis. Now, we'll just go ahead with the continuation of the last lecture, that is second line drugs. So why is there a need for the second line drugs? And before that, if you know, have a knowledge regarding the second line drugs, the second line drugs, majority of them are less effective and they are highly toxic. They are less effective and highly toxic. And the other thing regarding these drugs are they have to be taken on a regular, that is a daily basis. Not only that, why do you want to use this second line drugs? When is the requirement of second line drugs come into play? That means to say, whenever a person who is on first line drug will develop resistance to them, that is where we can introduce these second line drugs for the treatment of tuberculosis. Not only that, the second thing is, whenever there's a failure of clinical response to conventional therapy, that is first line management, when there is a failure of a clinical response, again, the necessity of second line drug arises. And the third issue is, whenever the first line drugs will result in development of serious ADRs, where it will force the patients to discontinue these drugs, and that is one area we are going to use the second line drugs. And apart from that, if there is an expert guidance available for the toxic effects of these drugs, then we are going to use this second line drugs. So these are the various reasons why or when we are going to introduce the second line. One is resistance to the primary drugs. There's a clinical failure with the first line drugs, and the first line drugs resulting in development of serious ADRs. This is an area where we are going to introduce the second line drugs. So what are these second line drugs? So we'll look into an individual drug. That is, the first and foremost drug is ETHIONAMIDE. And this ETHIONAMIDE, it is having a similar chemical structure as that of isoniazid. Hence, it acts similar fashion to that of isoniazid. But the mechanism of action is this ETHIONAMIDE, it blocks the synthesis of mycolic acids in the susceptible microorganisms, whereby it becomes very effective against resistant tubercle bacilli to other drugs. So it is effective against resistant tuberculosis bacilli, which occurs resistance to other drugs. It is also effective against atypical Mycobacterium tuberculosis infection. And this drug being poorly water soluble, and it is used as a oral preparation. This has another property where this drug is going to act both on extracellular and intracellular microorganisms. It is acting on both extracellular and intracellular microorganisms. And apart from that, if you look at the pharmacokinetic profile of ethionamide, as you know, this drug is similar to isonicotinic acid hydroside. It is very well absorbed to the GIT, but the major side effect with this is gastrointestinal tract irritant. It is a high irritant capability of this drug. So it is having an extensive GI irritability. Not only that, this drug is metabolized by the liver to various metabolites, and around 1% of the drug is excreted in the active form in the urine. So the dosage of this drug will be around 500 to 750 milligrams per day. And apart from that, if you look at, to start with, this drug has to be given, or it is available in the form of a tablet, 250 milligrams tablet, which has to be given daily. And the dose can be up titrated to 1 gram per day, or we can divide this dose according to the body weight, that is 15 milligrams per kg per day is the dose of ethionamide. Coming to the adverse drug reaction profile, as I told you that this particular drug is having an intense gastric irritation, and it is associated with development of serious skin rashes and alopecia. Apart from that, it may also cause purpura and anaphylactic shock. The common side effects are disturbances like GI disturbances, and this GI disturbance can be prevented or avoided by giving a single dose post-meal, preferably at night. Then this also causes optic neuritis or peripheral neuritis, which can be alleviated by giving pyridoxine in the form of a tablet, either 100 milligrams or 150 milligrams per day, along with ethionamide. Then it also has ADR profile with respect to endocrine disturbances. So the endocrine disturbances account to either gynecomastia, menorrhagia, and impotence. And these are very rare side effects with this particular ethionamide. Then ethionamide will also present with development of pellagra-like symptoms, which is rare, but still the stomatitis and other parts which affect the pellagra, especially due to vitamin deficiency. And apart from that, it may also cause hepatotoxicity. So it is having a battery of side effect profile extending from the GI to skin rashes to alopecia, anaphylactic shock to optic neuritis, and the endocrinal side effects like gynecomastia, menorrhagia, impotence, and pellagra and like syndrome, including hepatotoxicity, can also be seen with ethionamide. Then we come to next drug, which is called as CAPREOMYCIN. So this CAPREOMYCIN, it is a polypeptide which is obtained from Streptomyces capreolus, and this particular drug is highly water soluble and has a bactericidal action. When you come to the mechanism of action, CAPREOMYCIN has a similar mechanism of action as to that of streptomycin. So the streptomycin and CAPREOMYCIN are having the same mechanism of action. They act by inhibiting the protein synthesis, which then results in damage to the mycobacterial cell wall. And apart from that, CAPREOMYCIN becomes a very important agent for treatment of drug-resistant tuberculosis. And especially the strains which are resistant to amikacin are susceptible to CAPREOMYCIN. That means to say, the strains of Mycobacterium tuberculosis which are resistant to amikacin treatment, they are highly susceptible to CAPREOMYCIN. So amikacin resistant strains of Mycobacterium tuberculosis will work with CAPREOMYCIN. That means to say, this is a drug is highly efficacious when compared to amikacin resistant strains of Mycobacterium tuberculosis. And the dose of this drug is 15 milligrams per kg per day, which has to be given intramuscular. Then, if you look at the adverse drug reaction profile, as I told that this particular drug is having a similar action to that of streptomycin, and the ADR profile is also similar to streptomycin, like nephrotoxicity, ototoxicity, local pain, and sterile abscesses formation at the site of injection. So ototoxicity may vary from tinnitus to deafness and vestibular disturbances. So nephrotoxicity, ototoxicity, and local pain at the site of injection, and sterile abscesses formation at the injection site are very common with this particular capreomycin. Now, the next drug is cycloserine. So the cycloserine is an effective drug in tuberculosis as well as gram-negative infections. It is highly effective in tuberculosis as second-line drug, and also it is effective in treatment of gram-negative infections. And this particular drug is obtained from Streptomyces orchidaceus. It is highly effective against TB resistant to INH or streptomycin, and against atypical mycobacteria like Mycobacterium avium complex. This particular cycloserine is a structural analog of D-alanine. Hence, the mechanism of action is it acts by inhibiting the incorporation of D-alanine into peptidoglycan pentapeptide. So it inhibits the incorporation of D-alanine into peptidoglycan pentapeptide and inhibits the Mycobacterium cell wall synthesis. And apart from that, the pharmacokinetics is it is very well absorbed across the GIT, and the peak plasma concentration occurs within 4 hours. And it is distributed across the body and also the cerebrospinal fluid, especially when there is meningeal inflammation. So whenever there is inflammation of meninges or leptomeninges, this particular drug will percolate into the cerebrospinal fluid. And not only that, this particular drug is excreted 50% unchanged in the urine in 12 hours. Hence, the excretion is actually through the kidney. So any renal impairment will result in the toxicity of the drug. So we have to be very careful when we give a drug, especially in impaired renal disease, or there might be impaired renal or renal failure or a quiescent renal disease. Then apart from that, if you look at the adverse drug reaction profile, so the adverse drug reaction profile with cycloserine is mainly psychoneurotoxicity. So it results in causation of psychoneurotoxicity, where there is an involvement of the brain or dysfunction, or this sort of dysfunction of the brain, including depression and psychosis. And apart from that, cycloserine also causes a peripheral neuropathy, and it mainly presents with seizure disorder, especially in patients who are persons who are severe alcoholics, or patients who are on INH treatment, and in patients who are having chronic seizure disorders. There might be a presentation of seizures as a major adverse drug reaction with cycloserine. Apart from that, it may also result in development of tremors. So whenever we are giving this cycloserine in the management of this neuropathy, you have to remember that pyridoxine in the dose of 150 milligrams per day should be given with cycloserine, because this will reduce the neurological toxicity. So the dose of this cycloserine will be 250 milligrams as a tablet, and this can be given in either 2 doses of 0.5 grams BID in 2 or 3 divided doses. So 0.5 to 1 gram per day is the dose of cycloserine in the form of a tablet. Then we'll come to the another drug, which is called as para-amino salicylic acid, or PAS, PAS, para-amino salicylic. As you know, this para-amino salicylic acid is having a structural similarity to PABA, that is para-amino benzoic acid, and this is having a relationship with sulfonamide. So structurally similar to PABA and sulfonamide. So this particular para-amino salicylic acid acts by inhibiting the folate synthesis. So this is a folate synthesis antagonist. And apart from that, it is active exclusively against Mycobacterium tuberculosis, and it is a bacteriostatic drug. So having been a structural analog to PABA and sulfonamides, which do act by inhibiting the folate synthesis, or they are folate synthesis antagonists. So when you look into the dose of this drug, it is given in a high dose orally per oral. In the adult, it is around 4 to 12 grams per day, or if you go give for the children, it is around 300 milligrams per kg per day in children. Now, the pharmacokinetic and adverse drug reaction profile of this para-amino salicylic acid. This para-amino salicylic acid, it is readily absorbed across the GIT. It is widely distributed and it is excreted through the urine. When you talk about the adverse drug profile, it mainly presents with hypersensitivity reactions. It may also present with fever, joint pain, hepatosplenomegaly, hepatitis, granulocytopenia, adenopathy, and so on and so forth. And not only that, because of its high dose, it may also present with development of peptic ulcer and gastric hemorrhages. So this is regarding the para-amino salicylic acid, its pharmacokinetics and adverse drug reaction profile. Then if you look into the fluoroquinolones, in this fluoroquinolones, we do have moxifloxacin, ciprofloxacin, and levofloxacin. And these drugs, moxi, cipro, and levofloxacin, they are highly active against typical and atypical mycobacterial infections, even those which are resistant to other drugs. But especially these drugs have to be given intravenously. They are bactericidal in nature. When you talk about the ciprofloxacin, when you talk about levofloxacin and ofloxacin, they are also active in atypical Mycobacterium tuberculosis infections like MAC, that is Mycobacterium avium complex. And this levofloxacin and ofloxacin, they are having a long plasma half-life. Hence, they are given as once daily preparation. So whereas ciprofloxacin, it has to be given BID, but whereas levofloxacin and ofloxacin and moxifloxacin can be given as once daily preparation. Now, these drugs happen to be very important, especially for the strains resistant to first-line agents. So fluoroquinolones are very important drugs, especially if the patients develop resistance to first-line drugs used for the treatment of tuberculosis. So the very next group of drugs, what we give is fluoroquinolones like moxi, ofloxacin, or levofloxacin, or ciprofloxacin. Now, look into the dosage of these fluoroquinolones. They are especially ciprofloxacin, 750 milligrams BID per orally. Levofloxacin, 500 milligrams once daily per orally. Moxifloxacin, 400 milligrams once daily per orally. Then when you look at the mechanism of action of these fluoroquinolones, they mainly act by inhibiting the bacterial DNA synthesis. They inhibit the bacterial DNA synthesis by inhibiting the bacterial topoisomerase 2 and bacterial topoisomerase 4. That means to say, these drugs are going to act by inhibiting the bacterial DNA gyrase. Okay, they are DNA gyrase. They are DNA gyrase inhibitors. Fluoroquinolones are the drugs which act by inhibiting the DNA gyrase by inhibiting both topoisomerase 2 and topoisomerase 4. Henceforth, they inhibit the bacterial DNA synthesis. And apart from that, if you look into the adverse drug reaction profile, there's a battery of ADRs associated with fluoroquinolones. The major ones are, they cause photosensitivity, they cause damage to the growing cartilage, as well as these drugs, they cause tendinitis and tendon rupture. So damage to the growing cartilage, tendinitis, and tendon ruptures are the major adverse drug reactions associated with fluoroquinolones. Apart from that, they may also cause skin rashes, photosensitivity, slight headache, dizziness, insomnia, and GI side effects, which are very common with almost all the drugs. Then when you look into kanamycin and amikacin, So this kanamycin, streptomycin resistant strains. So there is one entity which is called as kanamycin, streptomycin resistant strains. But the availability of less toxic alternatives like capreomycin and amikacin. So as you know, kanamycin, which is an aminoglycoside, is highly toxic. It is highly toxic drug. So there are certain strains which are effective against kanamycin, or kanamycin is effective and streptomycin is effective against certain resistant strains. But there is availability of less toxic drugs like capreomycin and amikacin, which renders these kanamycin and streptomycin obsolete. So we are not using this kanamycin and streptomycin very frequently for the treatment of resistant strains because of the availability of less toxic drugs like capreomycin and amikacin. And apart from that, if you look at the amikacin resistance is very low. That is, prevalence of amikacin resistance is very low, and most MDR or most of this amikacin is active against MDR resistant tuberculosis. Okay, that means to say most MDR remain amikacin susceptible, or amikacin is highly effective against most of the MDR resistant Mycobacterium tubercle infections. And not only that, amikacin is very active against atypical mycobacteria like MAC complex. When you look at the dose of this amikacin or kanamycin or amikacin, forget about kanamycin, amikacin, it is 15 milligrams per kg as an intravenous infusion. Then we have another drug available in this category, second line management, that is your linezolid. So I would like to tell you one most important characteristic regarding this linezolid. So linezolid, as I already told you in the last class, that it is a drug which is grouped under macrolide like antibiotics. Okay, that is oxazolidinones. Okay, that is linezolid, oxazolidinones. Okay, so this linezolid has a very important characteristic feature with respect to its bioavailability. That is, when linezolid is given as an oral preparation also, it has 100% bioavailability when compared to intravenous route. So intravenous route and oral route, 100% bioavailability is seen with linezolid. And linezolid is grouped or categorized under third line drugs. Oh, so what are these third line drugs in the management of Mycobacterium tuberculosis second line, or the other drugs alternatives is the macrolides, clofazimine and linezolid are also called as third line drugs. They are also called as third line drugs. So as you know, macrolides like your clarithromycin and so on and so forth, like azithromycin and clarithromycin along with linezolid like drug. And of course, you know, clofazimine, it is a drug or an antibiotic which is used in the treatment of Mycobacterium leprae. This clofazimine is also a dye-based drug used in the treatment of M. leprae as well as for the treatment of, as a second line drug in the treatment of Mycobacterium tuberculosis. So this linezolid is used in combination with second and third line drugs in the treatment of MDR strains, that is multi-drug resistant strains of Mycobacterium tuberculosis. And apart from that, it is used with other drugs for MDR or XDR infections. And the dose is around 300 to 600 milligrams once daily orally. It can also be given intravenous preparation. It can also be given orally. Now, adverse drug reaction profile of linezolid, it causes more of bone marrow depression. Not only that, that is myelosuppression, bone marrow depression, and it also causes irreversible peripheral neuropathy. It may also cause optic neuropathy or neuritis. So these are the three major side effects of linezolid, that is bone marrow depression, myelodepression, irreversible peripheral neuropathy, and optic neuropathy. And apart from that, if you look at rifabutin or rifapentine, Now, this rifabutin and rifapentine, they are derivatives from rifamycin and are related to rifampicin. So rifabutin and rifapentine, they are derived from rifamycin and they are related to rifampicin. They have a significant activity against Mycobacterial tuberculosis as well as Mycobacterium avium complex. Apart from that, if you look at the mechanism of action, it has a similar mechanism of action as that of your rifampicin. That is, it acts by inhibiting the bacterial RNA polymerase. So it is an inhibitor of bacterial RNA polymerase. And the dose of this rifabutin is around 300 milligrams per day. Apart from that, this rifamycin is highly effective in prevention and treatment of atypical mycobacterial infections, especially in HIV and AIDS. So rifabutin and rifapentine are highly effective in prevention and treatment of atypical mycobacterial infections, especially in HIV and AIDS. And it has a similar inducer action with respect to the microsomal enzymes, but it is having a weak microsomal enzyme inducing action. So hence, it can interfere with other drugs. It can increase the metabolism of other drugs. So, but not as compared to that of rifampicin. It is having a weak enzyme inducer property when compared to that of rifampicin. Then, when I talk about newer drugs, so the newer drugs in the treatment of Mycobacterium tuberculosis. So what are these newer drugs available for the treatment of Mycobacterium tuberculosis infections? The newer drugs like bedaquiline. So this bedaquiline is also called as SIRTURO. It is also named as TMC 207, R20, 79, and 10. So all of these are nothing but bedaquiline. As I already told you, this bedaquiline is a drug which was known 40 years back, but it has been approved for use for the treatment of MDR and XDR, especially MDR and XDR, especially in the year 2012, to treat resistant TB or Mycobacterium tuberculosis infections. And this particular bedaquiline is a diaryl quinolone and a bactericidal, and it is a bactericidal drug which also acts on the dormant forms of bacilli. It is also active against the dormant forms of bacilli, both bactericidal, and it is also having action on the dormant stages of bacilli. So this is a very important drug. And this particular drug, the mechanism of action is it binds to the oligomeric and proteolypic subunit C of mycobacterial ATP synthase, which then leads to the inhibition of ATP synthesis and cellular death, that is the bacterial cellular death. But the most important adverse reaction with respect to bedaquiline is increased QT interval, abnormal and fatal cardiac rhythm and cardiac arrhythmias, which results in increased risk of death. So as I told you in the last class, this bedaquiline, we are doing active surveillance of bedaquiline in various designated centers across India, especially in which are attached to the Pharmacovigilance Program of India, and in association with the Ministry of Health and Family Welfare. There are designated centers wherein we are looking into the efficacy of bedaquiline in the treatment of resistant tuberculosis. And not only that, we are mainly looking into the adverse drug reaction profile, so that this drug may be very much useful in the management of resistant tuberculosis bacilli. So but as far as my knowledge goes, it might be around more than 1 year. The active surveillance is also happening in the attached chest hospital, but I could there was no reported ADR related with cardiac toxicity till now. Apart from that, if you look at the ADR profile of bedaquiline, it is nausea, joint pain, headache, and there's some abnormality in the liver, and there's an elevated liver enzyme profile with bedaquiline. So that this is regarding the bedaquiline, which is the most important drug, which has been tested by active surveillance across the country in various designated centers to look into the safety as well as the ADR profile with this particular drug in treating multi-drug resistant tuberculosis. Then we have the other drug available in this group, that is a newer drug, that is PRETOMANID and DELAMANID. So PRETOMANID and DELAMANID. PRETOMANID is called as PA824 and DELAMANID. These two drugs are available as newer drugs in the treatment of resistant tuberculosis. When you look at this PRETOMANID and DELAMANID, they are bicyclic nitroimidazole-like molecules, and they are highly active against both replicating as well as non-replicating Mycobacterium tubercle bacilli. They cause cell wall inhibition like isoniazid, and they are having a property of respiratory poisoning like cyanide. So they have cell wall inhibition property like isoniazid as well as respiratory poisoning property like cyanide. So they act by inhibiting the mycolic acid synthesis through unknown molecular mechanisms. So this particular PRETOMANID and DELAMANID, they act by inhibiting the mycolic acid biosynthesis through an unknown molecular mechanism. And the respiratory poisoning is thought to be through nitric oxide release. And these drugs are very safe and efficacious at a therapeutic dose of 100 to 200 milligrams, except that there might be chances of QT prolongation, which happens to be the major concern when it comes to the PRETOMANID, DELAMANID, as well as your BEDAQUILINE. So the QT prolongation and the cardiac toxicity is the major concern with respect to these two new group of drugs. Then, now you should know what is this DOTS. So DOTS is nothing but directly observed treatment, a short course, or directly observed treatment, a short course is the expanded form of DOTS. So why is there a need for this DOTS? As you know, when you talk about the symptomatology of tuberculosis, the patients commonly present with evening rise of temperature, there's low-grade fever, evening rise, there is cough extending for more than 3 months or 4 months, which is not being cured with other drugs. Then there is a malaise, there's decreased appetite, there's loss of weight, and so on and so forth. And it's being diagnosed to have tuberculosis, right? So these are the primary symptoms. So ESR is also very high and all those things. At the same time, when the patient is being treated with the primary first-line drugs, the symptoms, the symptomatology will get corrected and the patient feels to become normal, where his fever will come down, his appetite will increase, he will put up a lot of weight, and he will get a lot of energy. So then, but at the same time, we need to treat this tuberculosis for 6 months or 9 months, depending upon the patient. But what happens is, as and when the patient feels good, or he improves his health, he keeps eating, he puts on weight, and he becomes active and all those things, then he will stop the medication. So once the medications are stopped, there might be a relapse, and there is a defaulter, and there might be a reactivation in the later stages of the life. So to prevent these relapses or to prevent the default and all those things, this particular DOTS has been introduced by the governmental authorities. So what is this DOTS? DOTS is nothing but directly observed treatment, a short course. So why is this DOTS very important? Because you know, the purpose of the DOTS is to ensure cure by providing medicines and confirming whether the medicines are taken or not by the patient. So we are providing and confirming whether they are being consumed by the patient appropriately in appropriate time. The DOTS also has two phases. One is the intensive phase. The second one is the continuation phase. In the intensive phase, the patient swallows the drugs in the presence of a health worker or healthcare professional, right? In this continuation phase, the medicines are given for 1 week in a multi-blister combi pack. The medicines are given for 1 week in a multi-blister combi pack, and the first dose of those drugs has to be taken in the presence of the health worker or healthcare professional. And the next week medicines are only delivered to the patient only after he returns the empty blister packs. So this is regarding the continuation phase. So here, directly observed treatment short course is to ensure cure, providing medicines to the patient at their doorsteps and confirming whether the patient is consuming these medicines or not. It has two phases. One is intensive phase, where the patient swallows the drugs in the presence of the healthcare worker. In the continuation phase, 1 week of the medicine in the form of blister combi pack is given to the patient, and the first dose is taken in the presence of the healthcare worker. Then, next week, when the patient returns the empty blister pack, then only the next week dose is delivered to the patient, and again the first dose has to be taken in the presence of the healthcare worker. So here the advantages of this particular DOTS is, what are the advantages? The advantages of DOTS is there's a high rate of cure. Not only that, there is a decreased drug resistance, and as well as now we are looking into the efficacy of these drugs. The cure rate is more, drug resistance is reduced, as well as we are going to monitor the adverse drug reactions associated with these drugs, because the healthcare person is round the clock monitoring the patient who is consuming the drugs. So there is a high cure rate, there is reduced drug resistance, as well as the adverse drug reactions are monitored by the healthcare person, and the patient is also educated regarding the onset of certain adverse drug reactions like hepatotoxicity, neuritis, and all these things, or optic neuritis and all those things. Then, when you look into the chemotherapy, phases of chemotherapy with respect to anti-tuberculosis treatment, ATT, is the initiation phase of chemotherapy and the continuation phase of chemotherapy. Initiation phase is also called as intensive phase, and continuation phase is called as maintenance phase. Initiation or intensive, continuation or maintenance phase. So here in intensive or initiation phase, which will extend from 2 to 3 months, where we do give 4 or 5 drugs. And these 4 or 5 drugs which are included in the initiation phase rapidly kills the bacilli. And the drugs which are included in this are INH, rifampicin, ethambutol, and sometimes if there is a problem with this ethambutol, we can replace with streptomycin, or the fifth drug will be streptomycin. Then when you come to the maintenance or continuation phase, which will extend from 4 months to 6 months with 2 or 3 drugs. That means to say, initiation phase, it rapidly kills the bacilli, and the continuation or maintenance phase, it eliminates the remaining bacilli from the body. And this is going to prevent the relapse of the disease. So the drugs used are either INH or rifampicin or pyrazinamide. INH or rifampicin are the drugs used very commonly along with pyridoxine to combat the occurrence of peripheral neuropathy. So these are the phases with respect to chemotherapy of anti-tuberculosis treatment, ATT. Then, what is the classification of DOTS regarding the patients who are on RNTCP, that is Revised National Tuberculosis Control Program? So in this particular slide, you can see the disease is being categorized into category 1 and category 2. In category 1, we do have new sputum positive seriously ill patients. Then there are sputum negative patients, and they are seriously ill extrapulmonary patients. And there is sputum negative and extrapulmonary but not seriously ill patients. So all these categories of patients are being grouped under category 1. That is new sputum positive seriously ill patients, sputum negative seriously ill extrapulmonary patients, sputum negative extrapulmonary not seriously ill patients. And the regions are, we have 2 regions here again. One is the intensive phase and the continuation phase, or initiation phase and maintenance phase. In the initiation phase, which extends for 2 months, where we have HRZE regime. So H is isoniazid, R is rifampicin, Z is pyrazinamide, E is ethambutol, which has to be taken for 2 months. Followed by the maintenance phase, we have 2 drugs, isoniazid and rifampicin, which has to be taken for 4 months. So the category 1 treatment according to DOTS and RNTCP program categorized patients is for 6 months duration. Okay. Then when you come to the category 2, in category 2, we are having sputum positive relapses, and there is sputum positive failure, and sputum positive treatment after default. So sputum positive relapse, sputum positive failure, and sputum positive treatment after default. So in this, we are having an intensive phase which is extending for 3 months. There is a 3 months initiation or intensive phase. Again, this intensive phase is categorized, that is category 2 is being divided into 2-month intensive phase and 1-month intensive phase. In 2-month intensive phase, we have 5 drugs used. So what are these 5 drugs? HRZES, that is isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. And the next initiation phase, 1 month, that is HRZE, that is isoniazid, rifampicin, pyrazinamide, and ethambutol. So this is followed by the maintenance phase or continuation phase, where we do use 3 drugs, that is isoniazid, rifampicin, and ethambutol for 5 months. So in the category 2 of DOTS, where the sputum positive relapse, sputum positive failure, sputum positive treatment after a defaulter, is the total duration is for 8 months. Initiation phase is divided into 2 months and 1 month initiation phase. In 2-month initiation phase, we have 5 drugs to be given. 1 month initiation phase, we have 4 drugs to be given, and followed by continuation phase, that is for 5 months, we do give 3 drugs. So this is regarding the classification of DOTS in RNTCP, according to RNTCP. Then one should know what are the various definitions with respect to drug-resistant tuberculosis. So there are various definitions with respect to drug-resistant tuberculosis. Number 1, monoresistance. So monoresistance, as it spells, that there is a resistance to single drug. Then when we talk about polyresistance, resistance to more than 1 drug, but not the combination of isoniazid and rifampicin. Please remember, polyresistance is a resistance to more than 1 drug, but not the combination of isoniazid and rifampicin. That is polyresistance. And what is multi-drug resistant? Multi-drug resistance is resistance to at least isoniazid and rifampicin. If there is resistance to either isoniazid or rifampicin, or at least isoniazid and rifampicin, then it is called as multi-drug resistance. Then what is extensively drug resistance? XDR. MDR, XDR. XDR is extensively drug resistance. So it's MDR plus resistance to fluoroquinolones and at least one of the 3 injectable drugs like AMIKACIN, KANAMYCIN, and CAPREOMYCIN. Okay. So what is extended drug resistance? Extended drug resistance is nothing but XDR TB, which comprises of multi-drug resistance, that is either isoniazid or rifampicin, plus resistance to fluoroquinolones and at least one of the 3 injectable drugs like AMIKACIN, KANAMYCIN, and CAPREOMYCIN. So that is called as extensively drug resistant tuberculosis or XDR TB. Then the RNTCP'S regimens for multi-drug resistant tuberculosis. So when we talk about the RNTCP regimen for multi-drug resistant tuberculosis, it is categorized into intensive phase of 6 to 9 months and continuation phase for 18 months. So this is very important. So in multi-drug resistant tuberculosis, the intensive phase may vary from 6 to 9 months. Continuation phase or maintenance phase will be up to 18 months. So a total of say 24 months, or it may be around 27 months altogether. So what are the drugs used as an intensive phase? We have kanamycin, fluoroquinolones like ufloxacin, levofloxacin, ETHIONAMIDE, CYCLOSERINE, pyrazinamide, and ethambutol. So these are the 6 drugs or 7 drugs available in the intensive phase for MDR TB. And apart from that, when you look into the continuation phase, it is either ufloxacin or levofloxacin, ETHIONAMIDE, CYCLOSERINE, and ethambutol. So all these 4 drugs which come under your continuation phase. But along with these drugs, there should be a mandatory to give pyridoxine as 100 milligrams per day to combat the peripheral neuropathy or optic neuritis. Then, how do you treat the special cases of tuberculosis? There are certain special cases and the treatment modality of tuberculosis. Then, TB in pregnant women. So tuberculosis in pregnant women. What are the drugs which are safe for the management of TB in pregnancy? Especially isoniazid, rifampicin, pyrazinamide, and ethambutol can be safely given in pregnancy. And pyrazinamide is a drug which is not recommended in the United States of America. And the regime for treatment of tuberculosis and pregnancy is for 9 months. That is, 2 drugs have to be given. 3 drugs have to be given for 2 months. That is isoniazid, rifampicin, and ethambutol have to be given for intensive phase for 2 months, followed by maintenance phase for 7 months, that is isoniazid and rifampicin, which is combined with pyridoxine in the form of a tablet, either 100 or 150 milligrams per day. So pregnancy tuberculosis is not a contraindication for continuation of pregnancy. If at all the lady happens to be develop tuberculosis, especially if it is say the first trimester of pregnancy, one can plan for MTP. But if it is beyond the first trimester, enters into the second trimester, the pregnancy can be continued safely by using these 4 drugs. Okay, I have seen one patient with tuberculosis and pregnancy who has been subjected to POTS disease, resulting in POTS paraplegia, and the pregnancy was continued when I was an intern. The pregnancy was continued by giving this ATT. The lady has delivered the baby, and with due precautions and with milk feeding and all those things, there was a success in the delivery of that lady, and she has been successfully treated with these drugs, and that POTS paraplegia and psoas abscess was also drained. So that is my experience regarding the pregnancy and associated tuberculosis, and the pregnancy was continued with success. The lady also has recovered from tuberculosis. The paraplegia also recovered with a mild problem in her spine. Then tuberculosis in AIDS patients. So as I already told you that primarily tuberculosis was said to be a disease pertaining to the low socioeconomic groups, the people who stay in the crowded environment in the slums. But now that tuberculosis happened to be associated with HIV infections, and 5% of the TB patients, all the TB patients have to be screened for HIV now. So 5% of the TB patients are having HIV positivity, and HIV positive patients have higher incidence of extrapulmonary tuberculosis, severe and more lethal forms of tuberculosis. And the duration of treatment of tuberculosis and HIV patients extends from 6 months to 9 months. And the first intensive phase consists of 4 drugs for 2 months, which is followed by either 4 to 7 months of continuation phase of 2 drugs, like isoniazid, rifampicin, pyrazinamide, ethambutol for intensive phase for 2 months, followed by 4 to 7 months of isoniazid and rifampicin along with their antiretroviral treatment. So that antiretroviral treatment should not be stopped once you start on ATT. But at the same time, you have to monitor for adverse drug reaction profile. But especially in TB associated with AIDS, rifabutin and rifampicin is given for 9 to 12 months if the patients are on ART. So rifabutin or rifampicin is given for 9 to 12 months if the patients are on antiretroviral therapy. And especially with multi-drug resistant tuberculosis with HIV should be treated like non-HIV patients. So that means to say multi-drug resistant tuberculosis has to be treated like the non-HIV patients as the earlier regime what we have seen. Okay, the earlier regime what we have seen, we have to give the management for that particular. I'm sorry, I'll just go back. Yeah, in multi-drug resistant tuberculosis with HIV, it has to be treated like non-HIV patients by giving, say, KANAMYCIN, AMIKACIN, CAPREOMYCIN, pyrazinamide, ethambutols, and all those things. Okay, then this particular patients with HIV also have to be supplemented with pyridoxine. So here, the regime for treatment of tuberculosis and HIV patients is for 9 to 12 months, especially 2 months of intensive phase and 4 to 7 months of a maintenance phase with 4 drugs and 2 drugs respectively. Then when we talk about tuberculous meningitis has to be treated for longer duration of time, and 5 drugs are used in the continuation phase, and the continuation phase may be extended beyond 3 months. Means the 2 months or 6 months, it may extend beyond another couple of months for the treatment of TB meningitis. And in this TB meningitis, we need to give higher and higher doses of the drugs, especially as I told you, when you treat the tuberculous meningitis, the pyrazinamide is one drug which can cross the blood-brain barrier and which happens to be the mainstay in the management of tuberculous meningitis, and it has to be given in a higher dose like 1.5 gram and so on and so forth. Then when you look into the glucocorticoids in the management of tuberculous meningitis, when I talk about glucocorticoids, how does these glucocorticoids have a role to play in the management of TB and TB meningitis? As you know, glucocorticoids or corticosteroids are the drugs which impair the host defense mechanism and they promote the dissemination of infection. Not only that, they impair the host defense mechanism and they promote the dissemination of infection. So, per se, this glucocorticoid should not be used in the treatment of TB or TB meningitis, but its anti-inflammatory action or anti-inflammatory action of glucocorticoids may be very much helpful in this particular scenario. And these glucocorticoids should not be used without effective anti-tubercular treatment. So suppose we are going to use glucocorticoids, but as such, they impair the host defense mechanism and promote the dissemination of infection. But the anti-inflammatory property of glucocorticoids is utilized for certain conditions. So I'll tell you what these conditions are. And these glucocorticoids should be used, they should be used along with an effective anti-tuberculous treatment. So without anti-tuberculous treatment, simply if you give glucocorticoids, it will be a failure. You will be aggravating the disease rather than bringing it down. So what are the indications of glucocorticoids, especially in tuberculosis? There are certain indications of glucocorticoids in tuberculosis. The indications are, number one, they relieve the toxic symptoms and hypoxemia, which is rapidly progressive infection in the pulmonary tuberculosis. So here, glucocorticoids may act by relieving the toxic symptoms and hypoxemia rapidly and progressively infectious tuberculosis, pulmonary tuberculosis. And it is also useful in tuberculous pneumonia. It is also useful in miliary tuberculosis. So this is one of the indications of glucocorticoids. Then the glucocorticoids also will try to prevent the bronchial stenosis, especially in endobronchial tuberculosis. In endobronchial tuberculosis, what happens is there might be associated complications like bronchial stenosis. So glucocorticoids can be given to prevent bronchial stenosis, especially in endobronchial tuberculosis. Apart from that, glucocorticoids also prevent the formation of adhesions, and especially in conditions like hydrocephalus and arachnoiditis. So to prevent adhesions, especially in the brain, like whenever there's a hydrocephalus and there's a arachnoiditis, especially in tuberculous meningitis, these glucocorticoids will be useful in preventing the development of adhesions in arachnoiditis as well as in what is called as hydrocephalus. Apart from that, these glucocorticoids are also useful to counter the hypersensitivity reactions which are associated with anti-tuberculous treatment. Suppose you give a rifampicin or whatever drug, suddenly there is hypersensitivity reaction like anaphylactic shock or skin rashes. That is one area where we can use glucocorticoids. And apart from that, glucocorticoids also prevent serious complications in ocular and genitourinary tuberculosis. So these glucocorticoids also play a very important role, especially to prevent serious complications in certain subsets of tuberculosis like ocular tuberculosis as well as genitourinary tuberculosis. And one very most important feature we have to thing we have to remember regarding glucocorticoids is glucocorticoids are contraindicated, especially in abdominal tuberculosis. They should not be given for the treatment of abdominal tuberculosis because they may result in causation of the perforation of the intestines. So these are few indications of tuberculosis. These are few indications of glucocorticoids, especially in various disease conditions, and also they are used in the treatment of tuberculous meningitis. Then apart from that, if you look into the chemoprophylaxis of tuberculosis, so the chemoprophylaxis initially is used to prevent the progression of latent infection to acute tuberculosis. So we need to give chemoprophylaxis of drugs, especially to prevent the progression of a latent infection to active tuberculosis. And in chemoprophylaxis, we do have primary chemoprophylaxis and secondary chemoprophylaxis. In primary chemoprophylaxis, we do give INH 300 milligrams, that is 10 milligrams per kg daily for 6 months. And this is to prevent latent infection to enter into active pulmonary tuberculosis. Then secondary chemoprophylaxis is the one where in case of INH resistance, secondary chemoprophylaxis can be initiated by using INH 5 milligrams per kg along with rifampicin 10 milligrams per kg daily for 3 months. So this is regarding the chemoprophylaxis of tuberculosis. That means to say chemoprophylaxis is given to prevent the progression of latent infection of tuberculosis to active tuberculosis. Primary chemoprophylaxis we do give INH. Secondary chemoprophylaxis we give INH plus rifampicin. So finally, to come to an end, we do have this BCG vaccine. This BCG vaccine actually it is derived from a bovine mycobacterial bovine vaccine, and this vaccine is being used as a preventive measure, especially the newborn children from 0 to 45 days. And this vaccine is being used for the prevention of tuberculosis, and that is the vaccine available now. And the efficacy of this vaccine is again a bit controversial because the immunity with this vaccine may extend up to 5 years or 7 years depending upon the innate immunity. So this vaccine, it is derived from it is a bovine vaccine. Okay, so we do give this BCG vaccine to children, newborn children up to 45 days. We give intradermal injection of BCG vaccine, that is Bacillus calmette-guerin vaccine. Okay, thank you for your patient listening. Any doubts in this thing, you can ping me in the group. Thank you so much for your patient listening.